Bismillahirrahmanirrahim. Start the CME with the name of Allah, who is very, very kind, helpful, and merciful. Me, Dr. Tariq Ops, Gynae Family Emergency Specialist, presently working as Gulf KSA, presently working as District Gynecologist. A scenario for today's talk is a patient referred to you at 41 weeks for options advised and management. So you have to assess her, evaluate her, option to be counsel for options and the management. In this case, it seems to be active at 41 weeks, active induction of labor with expectant management. The most important thing is the evaluation of the expected date of delivery, especially through the ultrasound at the first trimester. Her risk factors for risk factors for urgent intervention be sorted out. There is increased incidence of meconium staining of liquor, fetal distress, fetal hypoxia, shoulder dystocia, and increased fetal death. There is also increase in neonatal seizures and death. And at 41 weeks, at 42 weeks, the neonatal mortality is doubled as compared to the 41 weeks. For management and counseling for options, active induction of labor versus expectant management, the patient wishes, her ultrasound findings, cervical examination, and ultrasound findings are very are important before management is being planned. The increased incidence of instrumental and operative deliveries and hemorrhage are also increased. The complications are increased at this 41 and 42 weeks, especially 42 weeks, in which the neonatal mortality is doubled. So you counseled her for the options. She is not willing for active induction of labor. For that, she needs to have antenatal monitoring testing, which is very important, is to be discussed, and she should be offered continuous electronic fetal monitoring, twice a week CTG and ultrasound for the maximum pool of the liquor. But with all this, she should be informed that it is not going to prevent the neonatal distress and the neonatal fetal death at this stage. And after seeing the ultrasound reports, she is now ready for active induction of labor. For that, you have to evaluate, do the CTG, and you also be ready for the fetal blood sampling and antenatal fetal monitoring, electronic fetal monitoring, CTG, continuous CTG, and all that. Important thing is the Bishop scoring. That will be used for planning the management, and this cervical screening is important. Nipple stimulation or the other options are there. Then labor can be induced. Active induction of labor can be done with prostaglandin E2, oxytocin, misoprostol, and membrane ruptures. There is a very important electronic fetal monitoring, continuous fetal monitoring CTG, and amnioinfusion for meconium staining of the liquor, and baby to be resuscitated by, if in distress, by a pediatrician. And there are increased chances of instrumental and operative deliveries, as I have said, in the hemorrhage, especially the postpartum hemorrhage. So one should be alert for it. With all considering medical and obstetrical risk factors, she should be planned for. Uh, she should be planned for elective for the C-section. So this at 41 weeks, active induction of labor versus expectant management, but they needs to have antepartum electronic fetal monitoring, fetal blood sampling, and CTG, continuous CTG monitoring, and antepartum antenatal testing is important, and the senior most obstetrician consultant advice should be there. So this is our takeaway. Thank you for the patients listening. We must not forget our past. We must pray, praise, talk, love, worship Allah, and follow the lifestyle of Sallallahu Alaihi Wasallam. Our health and survival. La ilaha illallah Muhammadur Rasulullah. And Allahumma ajirna minan nar. Ya Allah, save us from the fire of Jahannam. Wa kufa billahi wakila wa kufa billahi nasira. La ilaha illallah Muhammadur Rasulullah. And best wishes, all the best. Vama alayna illa al balagh. Will come with another review. Thank you.